So picture this. It's like a random Tuesday, and right around their lunch break, women are walking into these glossy aesthetic clinics.
Right. Happening all the time now.
Yeah, and they're paying literally thousands of dollars to have their own blood drawn, spun in a centrifuge, and then injected directly into, well, into their most intimate areas.
It sounds extreme, but it's a massive industry.
It really is. And, the marketing brochures in these waiting rooms, they are not subtle at all.
Oh, not even a little bit.
They're promising things like increased libido, heightened arousal, just mind-blowing orgasms. But if you actually bypass those pamphlets and look at the real clinical data...
Which is exactly what we're doing today.
Exactly. The science tells this remarkably different and honestly way more complicated story.
It really is a perfect case study. I mean, it's what happens when this huge cultural push for constant physical optimization just crashes right into regenerative medicine.
Right.
We're seeing these treatments jump from speculative science straight into commercial wellness spaces way before the clinical consensus has caught up.
And the intimate wellness market is like ground zero for this right now.
Absolutely.
Which is why we're doing this deep dive. We've got this massive stack of sources today to synthesize, all focused on platelet-rich plasma treatments for intimate health, specifically the O-shot for women.
Right, the very heavily marketed O-shot.
Yeah, and our mission here is to cut through all that commercial noise. We want to answer one very specific, totally burning question for you guys. Can this injection actually biologically improve sexual desire?
And to get there, we really have to navigate this huge gap in our sources.
Oh, it's a canyon.
Yeah. On one hand, we have promotional claims from over a dozen medical spas. And on the other, we have incredibly dense clinical data.
Which includes that 2024 cross-sectional analysis out of Oklahoma State University.
Right. Along with the comprehensive UNCC overviews on transvaginal therapies. And, crucially, a brand new 2026 randomized controlled trial that was just published in Obstetrics and Gynecology.
So let's start with the actual mechanics of the treatment.
Yeah.
Because, they call it a vampire treatment, which sounds like total science fiction.
It really does. But the biological premise is actually rooted in sports medicine and orthopedics.
Right. Platelet-rich plasma, or PRP. I was reading through the clinic protocols, and it's basically, well, it starts with a normal blood draw from your arm.
Yeah, just a small amount, usually 10 to 20 milliliters.
Okay, so they draw the blood, and then the supposed magic happens in the next step, right?
Exactly. They take that vial and put it into an FDA-approved centrifuge.
To spin it down.
Yeah, they spin it at very specific, really high speeds. And by doing that, they use specific gravity to separate the red blood cells out from the plasma.
Okay.
The whole goal is to isolate this layer we call the buffy coat.
The buffy coat. Sounds cozy.
Right. But it's actually just a super concentrated layer of plasma that is absolutely packed with platelets.
See, in standard high school biology, I just think of platelets as the little guys that rush to a cut to form a scab, to stop the bleeding.
Sure, yeah. But the literature shows their role in healing is way more complex than just making a scab. They are essentially these tiny biological reservoirs.
Reservoirs for what?
Well, they contain these structures called alpha granules. And when those are activated, they release a massive payload of growth factors.
Okay, so chemical messengers.
Exactly. Things like vascular endothelial growth factor, or VEGF. And these messengers travel into the tissue and basically act like an alarm clock.
An alarm clock for the cells?
Yeah, for dormant stem cells and fibroblasts. They tell the local environment to start angiogenesis, which is building new blood vessels, and to pump out collagen.
Okay, so the theory here is that you harness that concentrated signaling power. You apply a topical numbing cream down there, and then inject this liquid directly into the clitoris and the anterior vaginal wall.
That's the protocol, yeah. Often called the G-spot area.
And the clinics claim this whole thing takes, 30 to 60 minutes?
Usually, yeah. With zero downtime.
Wow. And you're basically banking on those growth factors, forcing the tissue to just rejuvenate itself over a few weeks.
Right. And I should mention, this science isn't just for women.
Oh, right, the P-shot.
Yeah, the male equivalent. They use PRP injections in the penis for erectile dysfunction. The goal is exactly the same. Grow new blood vessels to improve function.
Though the data there is just as debated, right?
Oh, completely. The
Yeah.
research is still very much ongoing.
So the analogy that kept popping into my head while reading this was like lawn care.
Okay, lawn care, I like that.
Right. It sounds like aerating a patchy lawn and then putting down this high-tech custom fertilizer made from your own body.
That's actually a really accurate way to visualize it, yeah.
You aren't just like painting the dead grass green. You're trying to stimulate new roots.
Yeah.
But here is my big question.
Let's hear it.
Is it really biologically possible to just inject desire into a person? I mean, the clinics are promising that this tissue repair equals spontaneous libido.
And that is the massive biological leap we need to scrutinize. To understand why women even seek this out, we have to look at the baseline.
Right, because nobody's volunteering for needles in that specific anatomy unless there's a real problem.
Exactly. The physical hurdle here is broadly categorized as female sexual dysfunction, or FSD, and it is incredibly common.
Yeah, the data said it affects roughly 50% of women seeking urogynecological evaluation.
It's a huge number. We're talking about a massive cohort dealing with severe vaginal atrophy. So thinning tissue, severe dryness, and dyspareunia.
Dyspareunia, which is the medical term for painful sex, right?
Yes, and that is a classic symptom of dropping estrogen levels, especially during perimenopause and menopause.
So if every time you attempt intimacy, you end up with physical pain or tearing, I mean, naturally, your psychological response is going to be avoidance.
Of course, your desire is going to absolutely crash. It's just basic pain avoidance wired into our nervous system.
Right. So traditionally, how does the medical field treat this atrophy? Because obviously they've been working on this for a while.
They have. And if we look at the NICE overview, they heavily evaluate energy-based devices, specifically transvaginal CO2 lasers and radiofrequency treatments.
Which I have to say, when I first read transvaginal lasers, it sounded pretty aggressive.
It does sound intense, but the mechanism is fascinating. It uses fractionated laser technology to create these microscopic thermal columns of damage in the tissue.
Oh, so it's exactly like those facial lasers for acne scars or wrinkles.
The exact same concept. You cause a tiny controlled microinjury to force the body's healing cascade to clear out old tissue and lay down fresh collagen.
And the NICE data shows this works, right?
It does. Studies show significant improvements in the vaginal health index and a reduction in dryness and pain.
But here's where it gets really interesting for me. I was looking at the randomized controlled trials.
Right.
And when you compare those high-tech lasers head-to-head with just standard, cheap, topical estrogen creams, the results are super mixed.
They are. The estrogen creams often perform just as well.
So if lasers and estrogen already have a proven track record for fixing the physical stuff like dryness and pain, why are women pivoting to injecting their own blood?
It's a great question.
Is PRP actually proven to be structurally better? Or is it just, the trendy, all-natural option on the wellness menu?
Well, the push for autologous treatments using your own biology is definitely driving this. A lot of patients are worried about systemic risks from hormone replacement.
Oh, sure, the HRT fears.
Exactly. And others are just intimidated by lasers. So PRP offers this really compelling story, right?
Yeah.
Your own body healing itself.
But does it actually work better?
Yeah.
Especially for desire. Because that's what the marketing is banking on.
And that question brings us to the core of this deep dive, contrasting those glossy brochures with the hard clinical reality.
Let's talk about that 2024 cross-sectional analysis by Hunt and his team out of OSU, because they really tried to audit this whole landscape.
They did. They started with 110 search results on PRP and female sexual dysfunction.
And after filtering for actual scientific rigor, they only had 18 clinical trials left to evaluate.
Right. And what they found in those 18 trials is pretty sobering.
Yeah.
They noted the methodology in many of these was just incredibly weak. Out of the 18, only 3 published results had consistent evidence for safety and physical efficacy.
3.
Yeah.
Out of 110 initial results. But the craziest part to me was when they looked specifically for data supporting heightened arousal or sexual satisfaction.
They came up completely empty.
Completely. Not a single study found statistically significant improvements in those specific areas.
Not one. The OSU analysis essentially proved that there is a profound disconnect between what the clinics are selling and what the science supports.
Which makes that brand new 2026 pilot RCT by Clark and colleagues so important.
Oh, it's crucial because this wasn't just a retrospective look. It was a new, randomized, placebo-controlled trial in obstetrics and gynecology.
They tested 52 premenopausal women, right?
Yes. Half got the real PRP injection.
And the control group.
They went through the exact same clinical theater, the blood draw, the centrifuge, the numbing cream, but they just got an injection of sterile saline, salt water.
Wow, okay. That double-blind setup is so important.
It is, especially in intimate wellness where the placebo effect can just be massive.
Right, so to measure the outcomes, they use the Female Sexual Function Index. The FSFI.
Exactly. It's a validated questionnaire that breaks function down into domains: desire, arousal, lubrication, orgasm, satisfaction, and pain.
And when I first looked at the total scores, I was like, wait, maybe the O-shot really is magic.
Because the total score went up?
Yeah. The PRP group had a median increase of 2.2 on the total score, while the saline group only went up 0.3.
It looks like a huge victory on paper.
If you stop reading right there, the marketing brochures look totally vindicated.
But, and there's always a bit, but the FSFI isn't just one number when they dug into the specific subscale scores.
For desire, arousal, and lubrication, the stuff people are paying for.
Right. Those specific scores in the PRP group did not reach statistical significance against the control group.
Wait, what does this actually mean? The so-called orgasm shot doesn't have statistically significant clinical proof that it increases desire compared to salt water.
Clinically speaking, no, it does not.
How is there such a massive gap between the marketing claims of like this instant libido boost and what these rigorous trials are actually proving?
Well, we have to figure out what the PRP is actually doing. Because like you said, the total score did improve.
Right.
And in that 2026 study, they also used another scale, the Patient Global Impression of Improvement, the PGI-I.
Oh, where the patients just rate how much they feel their overall condition improved?
Exactly, very subjective.
And the numbers there are completely wild. Nearly 70% of the women in the PRP group reported an overall improvement on that scale.
Right.
So how do we reconcile that? If their measurable actual desire didn't clinically change, why do 70% of them feel so much better?
We reconcile it by understanding the huge difference between treating a physical condition and treating psychological desire.
Okay, break that down for me.
The trials show that PRP is very safe, and it has really promising outcomes for the physical barriers of FSD.
So tissue health, elasticity.
Yes, and significantly, treating mild stress, urinary incontinence.
Right.
The growth factors seem to strengthen the vaginal wall, reducing the chance of leaking urine during exertion.
Okay, so think about the psychology here. If you're dealing with severe pain during sex, or you're just constantly terrified, you might leak urine if you laugh or jump.
The cognitive load of that anxiety is immense.
Exactly. Your libido is naturally going to flatline. Your brain sees intimacy as a source of pain or like profound embarrassment.
And desire is highly contextual. It requires a state of relaxation.
Right.
So when the PRP rejuvenates the tissue and sex isn't painful anymore, or your pelvic floor is reinforced so you aren't afraid of incontinence.
That massive psychological barrier is just gone.
Exactly. You aren't injecting desire, you are curing dread.
Oh, wow. Curing dread. I love that phrasing. So by fixing the physical discomfort, the psychological block is removed.
The clinical data completely supports that. PRP is not an aphrodisiac. It doesn't magically generate libido. It safely improves the physical environment so that your natural desire actually has room to exist again.
Okay, so it's like fixing a flat tire on a sports car.
Okay, back to the analogies. Let's hear it.
Right. So patching that tire doesn't upgrade the engine. It doesn't make the car inherently faster than it was built to be.
Right.
But, I mean, you sure aren't going to want to drive it at all if the tire is flat. The O-shot fixes the tire so you actually want to get back on the road.
That is exactly it. The marketing is selling an upgraded engine. They're promising spontaneous arousal.
But the clinical reality is just a really sophisticated tire patch.
Yes. Which is a fantastic outcome if you have atrophy or pain. It's just a totally different mechanism than what's on the billboard.
You know, there's another thing from that 2026 study that really stood out to me. The physical distension.
Oh, yes. The
Right.
mechanical action.
Yeah. The researchers noted that just the act of injecting liquid, even just the sterile saline, stretches the local tissue.
It does. It causes minor mechanical trauma.
Right, from the needle and the fluid.
Mm-hmm.
And that alone can actually trigger a localized healing response.
Which blurs the placebo effect even more. The body senses this micro-injury and rushes blood to the area to check it out.
So even the saline group is getting a mild healing cascade just from the physical injection.
Exactly. Which makes evaluating the true specific effect of the PRP growth factors really difficult.
Right, because if salt water can trigger a baseline healing response, the PRP has a really high bar to clear to prove it's actually the platelets doing the work.
And that's why these double-blind RCTs are the gold standard. They strip away the mythical status and force the treatment to prove its actual mechanism.
So as we wrap this up and look at all these sources, the big takeaway for you listening is really about medical literacy.
Absolutely.
I mean, vaginal platelet-rich plasma is this fascinating, generally safe application of regenerative medicine.
Using your own growth factors to stimulate angiogenesis is incredible science. And for women with real physical symptoms, atrophy, pain, mild incontinence, it clears the runway.
Right, it clears the runway for desire to return.
Mm,
But the rigorous data shows it does not directly create that desire.
it doesn't.
So in this world of glossy marketing and information overload, you have to respect the difference between treating physical symptoms and complex psychological responses.
Reducing the human sexual response to a simple injection just completely misunderstands our biology.
Totally. And I want to leave you guys with one final kind of provocative thought based on this deep dive.
Okay.
Think about the placebo effect we saw in that 2026 study. The women who got the saline-controlled salt water still saw a 0.3 increase in their total function scores.
They felt a subjective improvement.
Right. So if the placebo effect in sexual health is that strong, how much of desire is purely in our heads?
It's a huge question.
Could the mere act of taking charge of your intimate health, of booking the appointment and doing something for yourself, be the actual catalyst for a better sex life, regardless of what's even in the syringe?